Welcome to Lecture 7. In this lecture, we'll be talking about cross-sectional studies, case reports, and case series. By the end of this lecture, you should be able to describe the strengths, weaknesses, and common biases of cross-sectional studies, case reports, and case series. We're also going to be looking at using the Naranjo score to evaluate the probability of potential adverse drug reactions, so you'll be able to use that in your clinical practice. Let's start with a clinical dilemma. You're an aspiring pharmacist/epidemiologist. You've been reading more and more about the prevalence of burnout among members of the medical field. Burnout is a common disease state characterized by high workplace stress and decreased job satisfaction that's common in the medical field. Knowledge of burnout can lead to improve interventions in which employers and employees strive for an improved workplace environment and in general workplace happiness. You're curious to know whether burnout is also prevalent in pharmacists, but you have no money for a randomized controlled trial, and there's no available retrospective data to assess burnout rates. In other words, you likely need to conduct a survey in order to assess these burnout parameters in pharmacists in America. What type of study could you conduct to find an answer? The answer, as you probably guessed, is you would have to do a cross-sectional study to assess this research question. So let's talk a little bit about the design, the validity, and review the prevalence in the next couple of slides. As a reminder, this is our hierarchy of evidence. We started off with randomized control trials, and we've been trickling downward to cohort and case control studies. And now we're going further down the evidence chain to cross-sectional studies, case reports, and case series. Although they're very low quality of evidence, and although we won't be able to make causal assertions in looking at these studies, they still have their place in research, and we should still know how to use them effectively and how to interpret them appropriately. In general, a cross-sectional study can be considered an observational study in which the exposure and outcome are assessed at a single point in time, so they're assessed simultaneously. They're most commonly used in surveys or prevalence studies. If we're going through the classification system, they can be analytical or descriptive, meaning that we can simply describe what's happening in a population, or we can describe both outcomes and exposures and do some limited analyses. In terms of time orientation, cross-sectional studies are unique in that the exposures and outcomes are measured simultaneously at the same point in time. They're observational because there's no intervention from study investigators. We're simply measuring what already exists and what's already happening. If we look at our little model, we're selecting a population, measuring exposures and outcomes at one point, and then describing our results. So again, we are most likely going to encounter cross-sectional studies when we're describing current states of practice through surveys or current states of disease through prevalence studies in a larger population. In terms of causality assessment, there's no randomization, so there's no experimentation. We don't know if altering a cause alters the effect. We also do not know what that cause precedes effect because we're assessing the cause and effect simultaneously, so we don't know which came first and which led to which. This is called reverse causality, and we'll discuss it in a couple of slides. We can, however, still fulfill the requirement of the individual association if we collect data directly from individuals. For our clinical dilemma, we would survey pharmacists in the United States and ask them if they're currently burned out. We find that 30% are affected by burnout, and we simply describe our results. Burnout is prevalent among pharmacists, and maybe this leads to a different study in order to either further describe burnout and its causes or interventions in how to decrease it. The strength of a cross-sectional study is to describe the current landscape, whether you're describing current medical practice and procedures or you're measuring the prevalence of diseases. Either way, this information can be used to inform future studies and to generate hypotheses. So it's sort of a starting ground for delving further into a problem, or at least to assess the current state. And in terms of weaknesses, again, we can't determine that the cause precedes effects because we're assessing them simultaneously. And there's no assignment of treatment or exposure, so there's no experimentation. So we can't really make causal arguments when we read these articles. I included a slide here to review incidence and prevalence. As a quick review, incidence measures the cases of new disease in the population that are at risk for disease. It specifically excludes patients who already have the disease at the time the study begins. Incidence is very important in RCTs and other observational studies. However, in cross-sectional studies, we're almost always talking about prevalence. So if you see a cross-sectional study and you're wondering what statistics to calculate, it will be prevalence, because since we're assessing outcomes and exposure simultaneously at one point in time, there will be no time to develop new diseases. We're only caring about existing diseases. So if we were to calculate it, it would be prevalence equals the total cases of disease in the total population. And this is actually a lot more straightforward and intuitive. Again, in cross-sectional studies, we're collecting prevalence. So if you're asked to calculate a statistic, calculate prevalence because we're assessing it at a single point in time, so only existing cases. There are a couple of new biases that we need to introduce that are sort of specific to cross-sectional studies. And the first is reverse causality. Reverse causality broadly is the inability to determine whether a change in variable 1 causes a change in variable 2, or whether the relationship is actually reversed. That second variable is causing a change in the first variable. We don't know which is which because we're assessing them simultaneously. This is called the chicken and the egg problem. To take an example from earlier in this semester, when we identified that there was a positive correlation between ice cream purchases and murder, we were assessing these variables simultaneously at one point. So we can't tell if murderers are craving more ice cream or whether there's something in ice cream causing people to turn into murderers. All we know is that both are abnormally high and are positively correlated. There's an example in pharmacy in which many antibiotics are cleared by the kidneys, but antibiotics can also cause kidney damage. So if someone comes in with an acute injury to their kidneys and they can't clear the antibiotics out of their blood, then the blood levels of the antibiotics will be high. However, high blood levels of antibiotics can then injure the kidneys. So you're stuck in the situation where you can't tell which precedes the other. So some physicians would discontinue the antibiotic. At that point, that might be a poor decision. This is what is referred to as reverse causality. The second bias we'll look at is incidence prevalence bias, and this can be broadly defined as a skewed association between the exposure and the outcome when prevalence is used to estimate exposure instead of incidence. So by using prevalence instead of incidence, you can see an association that is not probably the true association. For example, say that you have a cross-sectional study in which you analyze cigarette smoking and emphysema simultaneously. You find oddly that cigarette smoking has a very weak association with emphysema, but this is because there are many patients who had emphysema at the time of assessment who had already stopped smoking. So you only caught their emphysema and you didn't catch the incidence of smoking because they'd already stopped, and they stopped because they had emphysema. Also, you're missing the patients who smoked at the time of assessment who did not yet have emphysema because it takes years to develop. To avoid this incidence prevalence bias, you would ideally conduct a longer-term observational study using incidence so that you can capture all the new cases, capture all those delayed diagnoses. You might end up with a more appropriate estimate of risk, say 2.0 instead of 1.1. Because surveys are likely the most common type of cross-sectional research that you'll encounter in practice, we need to talk a little bit about how survey studies choose their sample. Sampling is simply a method of selecting a subset of the target population in which you want to study. We've talked a little bit about this in other types of research, and there's a couple of ways to sample a population. The first and the most basic is the random sample, which is actually the most ideal sample because the subsequent samples should represent the broader population better than other types of sampling. A random sample is one in which a study population is selected using a random process. In other words, everyone has an equal chance to be included. This could be done via coin flipping, assigning random numbers to everyone in the population, and then picking, say, even numbers or numbers divisible by 3 or something like that. There's a variant of random sampling called stratified random sampling, in which you would randomly sample individuals in different strata. So you could randomly sample some individuals who are 55 to 65 years old and randomly sample some individuals who are 65 to 75 to ensure that you have an equal age distribution, but you're still randomly sampling within those distinct strata. Then there's what's called a convenience sample, which is a non-random sample of respondents that are available to a researcher at a specific place and time. Essentially, you're sampling participants who are convenient for you to sample. An example of this would be sampling patients who come to your pharmacy on your particular shifts, or me sampling students who are currently in the LRC. It's not a random sample, and it's probably not a representative sample. You're just simply picking who is easiest to study, who is nearby at that point in time, and it doesn't necessarily mean that you'll get a sample that is representative of the larger population. Then there's a purposive sample, which is another non-random and non-representative sample of patients who have the desired characteristics for the study. This is kind of narrowing down your study population into only a specific small cohort. So instead of analyzing everyone who came into your pharmacy, you could analyze only elderly patients or only patients who take cough suppressants. So it's getting a little bit of a narrower sample. And finally, since cross-sectional studies are our last type of observational study, I just want to point out that there are many other types of studies that we're not going to go into depth in this course. Other observational studies would include things like pre-post studies, in which researchers are examining the effects of an intervention before and after an intervention takes place. For example, you have an intervention where a pharmacist sees patients who are diabetic for 6 months in a row. You could compare blood glucose levels of the same patients both before and then 6 months later to see if the pharmacist had an impact. There are things called time series analyses, which are essentially pre-post studies with more observations. You take multiple observations over time after and during an intervention, and you assess the change over time to see if you've had a significant outcome. Some examples of this they sometimes look at how statins are prescribed over time. After one of the medications becomes available generically. So sometimes you see a spike in statins over time. Finally, there are ecological studies in which they're fairly similar to observational studies, but they make comparisons between groups of individuals rather than individuals themselves. An example of this would be a common type of research right now is comparing opioid deaths or opioid overdoses in states that have legalized marijuana and comparing them to states that have not legalized marijuana. So you're looking at them on the group level. It's not important for you to study these in particular. This is more of an FYI just to make sure you know there are other types of research designs out there.